One defect narrows the pipe. The other, well, it turns a part of the heart into something it absolutely shouldn't be. When we look at right heart failures, the clinical reality is often way more dramatic than what you read in a textbook. Today, we're not just memorizing symptoms, we're looking at two completely different mechanical and architectural disasters that demand immediate, decisive intervention. Welcome back to The Explainer for your cardiovascular and thoracic surgery block. I know your time as medical students is tight, so we're skipping the basic anatomy review. We are jumping straight into the core of congenital right heart defects, breaking down the exact mechanics of these pathologies so you can visualize exactly what's failing inside your patients. So here's our game plan for today's rapid review. 1. The two logics of breakdown. 2. Pulmonary artery stenosis. 3. Epstein anomaly and atrialization. 4. Genetics and risk factors. And 5. The surgical fixes, specifically the balloon and the cone. Section 1. Two logics of breakdown. We're going to contrast a straightforward, brute force obstruction with a complex spatial displacement of the heart's architecture. For pulmonary artery stenosis, I want you to imagine a heavy-duty pump forced to push thick fluid through a partially crushed pipe. That's the mechanical reality here. You narrow the exit, and the right ventricle is forced to act as a pump working on extreme wear and tear just to maintain basic pulmonary blood flow. The compensatory mechanism is pure brute force. The pressure inside the right ventricle skyrockets, leading directly to severe right ventricular hypertrophy. The pump doesn't shatter right away. Instead, the muscular walls get dangerously thick, the expulsion period lengthens, and the myocardium becomes incredibly overworked until it ultimately just fails. This is exactly why your patient presents with right-sided heart failure signs so rapidly, like jugular venous distension and peripheral edema. The whole system is simply backing up. Section 2. Pulmonary artery stenosis. Now, the crucial point here is treating these echo pressure gradients as a rapid clinical tool to gauge severity in real time, rather than just treating it like a textbook list to memorize. When you're assessing this using continuous wave Doppler, you're measuring the velocity of the blood jet to calculate the pressure difference. A peak gradient under 36 millimeters of mercury, that tells you the obstruction is mild. But once you cross that 64 mark, you're in severe territory. The higher the gradient, the harder that pump is struggling against the narrowed pike. That number is your immediate trigger for deciding on intervention before the right ventricle completely gives out. An echo is exactly how you rapidly prove you've got an obstructed pipe. You're obviously looking for that right ventricular hypertrophy we just talked about, but you'll also need to watch for the post-stenotic expansion of the pulmonary artery. Why does that happen? Well, the blood shooting through that tiny stenotic valve opening creates a high-velocity turbulent jet that literally stretches the arterial wall just past the valve. It's a classic, undeniable sign of an exit obstruction, confirming exactly why the ventricle is working on overdrive. Okay, let's switch gears. And now, a defect with an entirely different logic of breakdown. We are leaving the simple blocked pipe behind. I need you to forget pressure gradients and brute force pumps for a moment. We have to completely reset our mechanical understanding for what comes next. Section 3. Epstein anomaly and atrialization. We are shifting from a simple blockage to a total architectural disaster. This brings us to the climax of today's review: atrialization of the right ventricle. In Epstein anomaly, a massive portion of this anatomical chamber physically ceases to be what it was built for. Because the tricuspid valve is displaced downward, deep into the ventricle, the upper portion of the right ventricle totally transforms. It stops acting like a contracting pump and becomes this passive, thin-walled reservoir that acts as a single continuous cavity with the right atrium. You are literally losing the engine of your right heart. Hemodynamically, this is devastating. It leads to a massive decrease in cardiac output to the lungs and severe backup of venous blood, which fundamentally ruins the patient's circulatory stability. Let's break down exactly how this spatial displacement happens step by step. Step 1. During fetal development, the septal and posterior leaflets of the tricuspid valve fail to delaminate or detach from the underlying heart muscle. Step 2. This developmental failure pulls the functional tricuspid valve annulus apically deep down into the right ventricle. Step 3. Because of this displacement, the true functional volume of the right ventricle is drastically reduced. And to make matters worse, this unbalanced deformation usually creates a really dangerous circular shunt. Blood just regurgitates back and forth completely uselessly between the true ventricle and the atrialized portion, causing massive progressive dilation of the right heart without actually pushing blood forward into the pulmonary circulation. To quantify this extreme structural severity, we use severity indices like the Seller-Maget, also known as the GOES, and the SAS index. Basically, these ratios compare the area of the right atrium and the atrialized right ventricle against the rest of the functional heart chambers. Just look at grade 4, a ratio of 1.5 or greater. If the natural course is left unchecked, neonatal mortality risk hits basically 100%. This isn't just a leaky valve, right? It's a catastrophic loss of functional anatomy that requires an entirely different surgical approach than a simple stenosis.
Section 4, Genetics and Risk Factors. While Epstein anomaly is pretty rare, we do know of specific triggers. Genetically, heterozygous missense mutations in the NKX2.5 gene, which is a key regulator of heart development, and mutations in the MYH7 gene are heavily implicated. Environmentally, maternal lithium exposure during the first trimester is a major known risk factor that can disrupt early embryogenesis. Keep these firmly in the back of your mind for clinical history taking, as they are definitely high yield, but let's get back to how we actually fix the mechanics.
Section 5. Surgery, balloon and cone.
Here's where we see a dramatic difference in how we intervene. For our narrowed pipe, the pulmonary artery stenosis, we utilize balloon valvulopathy. It's an elegant, minimally invasive catheter procedure where you simply force open the fused commissures of the valve, relieving that pressure gradient instantly. Boom. Done. But for Epstein's architectural failure, a balloon is completely useless. You require open surgery. You have to use cone reconstruction to completely rebuild the anatomy from scratch.
The cone reconstruction is incredibly progressive. Pioneered by Dr. Da Silva, this technique detaches the displaced, deformed leaflet tissue and literally sews it into a 3D cone shape, bringing it back up to the true anatomical valve ring. It essentially reverses the atrialization and is vastly superior to older plastic methods because it drastically reduces tricuspid regurgitation. Now, it's really important to mention that for extreme, critical neonatal cases where the right ventricle is just simply too small to save, the Starnes procedure remains an extreme last resort. That involves closing off the tricuspid valve entirely and placing a right atrial to pulmonary artery shunt, bypassing the failed right ventricle completely so the newborn can at least survive.
Let's bring this all full circle. We started this review with two distinct realities: the simple, brutal physics of a narrowed pipe and pulmonary stenosis, forcing the pump to hypertrophy and work on extreme wear and tear. And contrasting that, we have the complex, devastating structural collapse of the atrialized ventricle and Epstein anomaly. Two distinct right heart defects requiring completely different paradigms of mechanical understanding and surgical repair.
But understanding the mechanics is really just step 1. Applying the latest clinical guidelines on the floor is step 2. How will the new 2022 to 2025 clinical protocols change your approach to actually managing these right heart defects in practice? Well, we are covering exactly that in our next deep dive explainer. So hit subscribe to make sure you're fully prepared and you don't miss our breakdown of those highly anticipated new protocols. Keep studying hard, and I will see you in the next one.